Welcome to the Hospital Medicine Unplugged podcast.
Great to be here.
Today we're diving deep into a topic that's absolutely fundamental to inpatient care. Evidence-based venous thromboembolism prophylaxis. VTE prophylaxis.
It's a cornerstone of patient safety, really.
Absolutely. And we're going to be grounding our discussion in the latest evidence and key guidelines, pulling from the American Heart Association, the ACC, and CHEST to kind of synthesize what best practice looks like right now.
And it's so important because VTE, encompassing both deep vein thrombosis and the potentially lethal pulmonary embolism, it remains a huge cause of preventable harm in hospitalized patients globally.
The scale is quite staggering when you look at the numbers.
It really is. The estimated annual incidence is somewhere around 1 to 2 per 1,000 adults. But the critical thing is that risk isn't static. It climbs exponentially with age, and particularly when someone becomes acutely ill and hospitalized.
That exponential increase is exactly what makes this such a challenge in hospital medicine. And while, maybe 2/3 of these VTE events show up as a DVT, which is serious enough,
right,
it's that other third, the pulmonary embolism, that really drives the mortality figures. It's the PE we're ultimately trying to prevent.
Precisely. And historically, the approach was often, maybe a bit broad brush, almost universal prophylaxis for many admissions.
Kind of a default setting, yeah.
But the evidence, and certainly the guidelines now, have pushed us firmly toward much more sophisticated, individualized strategies, really tailoring it based on validated risk models.
So the core idea, the mission for this deep dive, is to move past just ticking a box.
Exactly. It's about strategically identifying which patients genuinely stand to benefit most from prophylaxis, getting that significant VTE reduction, while, crucially, minimizing the harm from bleeding.
That bleeding risk is the other side of the coin, always.
It is. It's a delicate balance, and that's what the best evidence and guidelines try to help us navigate.
Okay, so let's start right at the beginning, the basic pathophysiology. Why do hospitalized patients get clots? We always come back to Virchow's Triad, don't we?
We do. It's the classic framework, and it holds up remarkably well. Hospitalization basically creates the perfect conditions to activate all three parts of the triad.
So let's break those down. First leg, venous stasis.
Right, venous stasis. This is probably the most obvious one in the hospital. Patients are immobile. They're in bed due to illness, pain, post-op recovery.
They're just not moving like they normally would.
Not at all. And that lack of movement, specifically the lack of the calf muscle pump contracting, leads to blood pooling in the deep veins of the legs. Blood flow slows right down, sometimes dramatic.
Start creating a perfect little incubator for a clot.
Exactly. Platelets can aggregate, clotting factors can accumulate locally. It's prime territory for thrombus formation.
Okay, so that's stasis. Then the second part of the triad, endothelial injury.
Endothelial injury. Now, we often think of this with major trauma or big surgeries, and that's certainly true. Direct damage to the vessel lining.
Yeah, like orthopedic surgery.
Definitely. But it's broader than that in hospitalized patients. Acute illness itself, think severe sepsis, pancreatitis, even a heart attack triggers systemic inflammation.
And inflammation damages the endothelium.
It does. Those inflammatory cytokines circulating can cause subtle but significant injury to the delicate endothelial lining of the veins. Plus, you have direct insults like central line insertions, peripheral IVs. Those create localized injury sites too.
Makes sense. So we have slow flow and we have damage to the vessel wall. What's the third piece?
Hypercoagulability. This is the state where the blood itself is sort of primed to clot more easily.
Like in patients with cancer?
Cancer is the classic example, yes. Malignancy often induces a hypercoagulable state. But again, acute illness itself plays a huge role here too.
How so?
Conditions like severe heart failure, bad infections, respiratory failure, they trigger the release of acute phase reactants from the liver. Things like fibrinogen go up, natural anticoagulants might go down. The whole hemostatic balance shifts towards promoting clot formation.
So even before there's significant stasis or obvious injury, the blood itself is just stickier.
In a manner of speaking, yes, it's more prothrombotic. So you put these three together, stasis, endothelial injury, and hypercoagulability, and you see why the hospital environment is such a high-risk setting for VTE.
Which is why the major organizations, the AHA, ACC, are so clear about this. They mandate systematic risk assessment and appropriate prophylaxis. It's not just good practice, it's a core safety and quality measure.
Absolutely. It's built into performance metrics for hospitals because failing to address VTE risk has serious consequences.
And are interventions tied directly back to disrupting that triad, right?
Precisely. Pharmacologic prophylaxis heparin, LMWH, fondaparinux, they work primarily by interfering with the coagulation cascade, damping down thrombin generation. That directly tackles the hypercoagulability component.
Okay, and mechanical methods.
Mechanical prophylaxis, like intermittent pneumatic compression devices, or IPCs, they directly target the stasis. They physically squeeze the legs, mimicking the muscle pump, improving venous return, and reducing that pooling of blood.
So different tools targeting different parts of the problem.
Exactly. The goal is to break that vicious cycle set up by Virchow's Triad in the hospitalized patient.
Okay, so knowing we need to intervene, how do we do it smartly? This brings us to the shift away from universal prophylaxis towards individualized, risk-adapted strategies.
This is probably the biggest evolution in VTE prevention in recent years. It's all about precision.
Why the shift? What was wrong with the old way?
Well, the realization was that giving anticoagulants to everyone inevitably exposes many, many patients who are actually at very low risk of VTE to the harms of the drugs, primarily bleeding.
Right, you cause harm without providing much benefit in that low-risk group.
Exactly. So the paradigm now is simultaneous risk assessment. You absolutely have to assess the patient's VTE risk, but you also have to assess their bleeding risk at the same time. The decision comes from balancing those two.
And that's where the validated risk scores become non-negotiable tools.
They are essential. We can't just guess or go on gut feeling. Using a validated score ensures consistency and adherence to evidence. They are decision aids we really must use.
Let's tackle the medical inpatients first, probably the largest group we see. For acutely ill medical patients may be admitted with pneumonia, heart failure exacerbation, COPD flare, the key tool is the Padua prediction score.
That's right. The Padua score was specifically developed and validated for this population. Acutely ill, non-surgical patients who are likely to have their mobility restricted.
What goes into the Padua score? What factors does it consider?
It aggregates several well-established VTE risk factors, things like active cancer, a personal history of VTE, known thrombophilia, severe immobility.
How is immobility defined there?
It's usually defined as anticipated bed rest with minimal, maybe just bathroom privileges for at least 3 days.
Yeah.
That carries significant weight.
Okay, what else?
It also crucially includes markers of the acute illness itself.
Oh.
Recent trauma or surgery, advanced age, often over 70, heart or respiratory failure, acute infection or a rheumatologic disorder, obesity, BMI over 30, and ongoing hormonal treatment.
And each factor gets points.
Yes, each factor is assigned points, reflecting its relative contribution to risk. Some factors weigh more heavily than others.
Which ones carry the most weight in the Padua model?
The big ones, scoring 3 points each, are active cancer and previous VTE. History really matters.
Makes sense. What gets 2 points?
2 points are given for reduced mobility, as we just defined it, and also for having a known thrombophilic condition, like factor V Leiden, for example.
And then other factors get 1 point, like age, heart failure, infection.
Exactly. Things like age over 70, heart or respiratory failure, acute MI or ischemic stroke, acute infection or rheumatologic disease, obesity, those each add 1 point.
So you tally up the points. What's the magic number? What's the action threshold?
The threshold is clear and validated. A Padua score of 4 or greater, OF4, defines a patient as being at high risk for VTE.
And those high-risk patients warrant pharmacologic prophylaxis.
Yes, assuming their bleeding risk is acceptable. A score of 4 or more is the trigger for initiating pharmacologic VTE prevention.
What about patients with a score less than 4?
Patients scoring less than 4 are considered low risk. The evidence suggests that for these patients, the risks of pharmacologic prophylaxis generally outweigh the potential benefits. So unless there's some other compelling reason, they typically don't receive anticoagulation. They might get early ambulation, maybe mechanical prophylaxis if they have contraindications to moving, but not drugs.
Okay, that seems pretty straightforward for the medical side. Padua score, threshold of 4. Now, let's switch gears to surgical inpatients. Here, the go-to tool is different. The Caprini risk score.
Right. The Caprini score is the standard for surgical populations, and it's a different beast compared to Padua.
How so? More complex.
Definitely more complex, much more granular. It includes over 40 potential risk factors. It digs deeper into the specifics of the surgery itself, the type, the duration, whether it's major or minor. It also incorporates a wider range of comorbidities and patient-specific factors.
Over 40 factors, that's comprehensive.
It is. It looks at everything from age, BMI, history of VTE, cancer, inflammatory bowel disease, to the specifics of the planned operation, orthopedic, vascular, abdominal, thoracic anesthesia time, presence of central lines, immobility duration. It aims for a really nuanced assessment of that individual patient's perioperative VTE risk.
And how does it stratify risk? Does it give a simple high-low cutoff like Padua?
No, it provides a more layered stratification. Patients are typically grouped into risk categories based on their total score. Very low risk, score 0-2, low risk 3-4, moderate risk 5-6, and high risk, a score of 7 or greater, sometimes stratified even further like 7, 8, and 9+.
So multiple tiers of risk. Where does the evidence show pharmacologic prophylaxis actually makes a significant difference in surgical patients? Is it everyone above very low?
This is a really critical point, and sometimes a source of confusion or debate in practice. The robust evidence from large studies and meta-analyses indicates that the significant, clinically meaningful reduction in VTE events with pharmacologic prophylaxis is seen primarily in the highest risk group.
Meaning those with a Caprini score of?
Generally a score of 7 or greater.
Yeah.
7. That's the threshold where the benefit of anticoagulation consistently outweighs the bleeding risk in major surgical studies.
So patients scoring in the moderate range, say Caprini 5 or 6, the benefit isn't as clear-cut.
Exactly. While their risk isn't zero, the data suggests that routinely giving pharmacologic prophylaxis to patients with scores of 6 or below might expose them to increased bleeding complications without a commensurate significant reduction in VTE events. The net benefit is questionable in that group.
That's crucial. So we really need to resist the urge to treat based on a moderate score alone, unless perhaps their bleeding risk is exceptionally low.
Precisely. The data pushes us to reserve pharmacologic prophylaxis for those Caprini 7+ patients, the ones undergoing major surgery, often with multiple other risk factors like advanced age, cancer, prior VTE. For scores below 7, the standard recommendation is often mechanical prophylaxis like IPCs and early ambulation, unless specific circumstances warrant otherwise. It's about maximizing net benefit, not just preventing any theoretical clot.
Okay, so we use Padua for medical, Caprini for surgical, identify the high-risk group, Padua for 4, Caprini 07. Now, what are our go-to pharmacologic agents for these high-risk patients?
The workhorses remain the heparins, specifically low molecular weight heparin, LMWH, and unfractionated heparin, UFH. Fondaparinux is another option as well.
Let's start with LMWH. That seems to be preferred in many guidelines.
It often is, yes. Enoxaparin is the most commonly used LMWH. The typical prophylactic dose is enoxaparin 40 milligrams injected subcutaneously once daily.
Why the preference for LMWH over UFH?
Several reasons. LMWH has more predictable pharmacokinetics, meaning the anticoagulant effect is more consistent dose to dose and patient to patient. It generally doesn't require routine monitoring like UFH sometimes does. And importantly, it has a significantly lower risk of causing heparin-induced thrombocytopenia, or HIT, compared to UFH.
Okay. But UFH is still widely used. What's the standard prophylactic regimen for that?
For unfractionated heparin, the typical prophylactic dose is 5,000 units injected subcutaneously. The frequency can be either 2 times daily, every 12 hours, or 3 times daily every 8 hours.
Why the variation in frequency for UFH by D versus TI?
Good question. The BD dosing every 12 hours is common for many general medical or lower-risk surgical patients. The TID dosing every 8 hours provides more sustained anticoagulation and is often preferred in higher-risk situations, like major orthopedic surgery or some critically ill patients, based on the idea it might offer slightly better efficacy.
But potentially higher bleeding risk with TID.
Potentially, yes. There's a slightly increased risk of bleeding with the more frequent dosing. So the choice between BID ED and TID often depends on the perceived level of VTE risk versus the patient's bleeding risk. And sometimes institutional protocols guide this.
And the third option you mentioned, fondaparinux.
Right, fondaparinux. It's a synthetic drug, a selective factor bison inhibitor. The prophylactic dose is 2.5 milligrams subcutaneously once daily. It's an alternative, particularly useful in patients with a history of HIT as it doesn't cross-react.
Okay, those are the established subcutaneous agents. What about the newer players, the direct oral anticoagulants, the DOACs? We hear about agents like Betrixaban or rivaroxaban being studied for VTE prophylaxis.
Yes, there has been significant research into DOACs for VTE prevention, particularly focusing on extended prophylaxis, meaning continuing the medication after hospital discharge.
Tell me more about that. Betrixaban had a notable trial, didn't it?
It did. The APEX trial looked at Betrixaban versus standard enoxaparin prophylaxis in acutely ill medical patients, but continued the Betrixaban for an extended period, around 35-42 days total. It did show a reduction in VTE events compared to shorter duration enoxaparin. Rivaroxaban has also been studied in similar settings, like the Magellan trial.
So they showed efficacy. Why aren't they the standard for extended prophylaxis post-discharge for most medical patients?
The major limiting factor, and the reason why routine extended prophylaxis with DOACs isn't recommended by most current guidelines, is bleeding.
Ah, back to the balance.
Exactly. While these trials showed a reduction in VTE, they also consistently showed an increase in major and clinically relevant non-major bleeding compared to placebo or standard short-duration prophylaxis.
So the number needed to treat to prevent a VTE was maybe offset by the number needed to harm from bleeding.
Precisely. When you looked at the net clinical benefit, it often wasn't clearly positive for the broad population of acutely ill medical patients. The benefit in VTE reduction was counterbalanced or sometimes outweighed by the increased bleeding risk.
So is there any role for DOACs in extended prophylaxis?
There might be a role, but it's currently reserved for a very carefully selected narrow group of patients. These would be individuals deemed to be at particularly high ongoing VTE risk after discharge, maybe someone with limited mobility due to stroke, or certain active cancers who also have a demonstrably low risk of bleeding. It's not for routine use. For standard inpatient prophylaxis, LMWH and UFH remain the primary choices.
Okay, that clarifies the role of DOACs. Now let's pivot to perhaps the most critical aspect of this whole process, safety. When do we absolutely have to withhold pharmacologic prophylaxis because the bleeding risk is just too high?
This is paramount. Overlooking bleeding risk can be catastrophic. Guidelines, like those from the American College of Physicians, are very clear on contraindications.
What are the absolute stop signs?
Top of the list is active major bleeding. This isn't trivial bleeding. We're talking about ongoing significant hemorrhage. Clinically, this might be defined as recent GI bleeding, say within the last few months, or significant GU bleeding. Critically, any history of intracranial hemorrhage within the past year is generally an absolute contraindication due to the high risk of rebleeding with anticoagulation.
Makes sense. What about baseline hematologic issues?
Absolutely. Severe thrombocytopenia is a key one. The usual cutoff is a platelet count below 50,000 per microliter, 50 by 10 Darrell. Anticoagulating someone with severely low platelets is asking for trouble.
And HIT history.
A definite history of heparin-induced thrombocytopenia, HIT, is an absolute contraindication to using any heparin product, UFH or LMWH. You need to use an alternative like fondaparinux or potentially a DOAC if anticoagulation was deemed essential, but typically mechanical prophylaxis is the first step. Known hypersensitivity to heparins is also a contraindication.
What about underlying coagulopathy, like liver disease?
Yes, significant underlying coagulopathy. This is often assessed by the prothrombin time, PT or INR. A PT greater than 18 seconds or an INR significantly elevated, say over 2, in the absence of therapeutic anticoagulation, suggests an intrinsic bleeding tendency that makes prophylactic heparin risky.
And recent procedures.
That's another big category. Recent high-risk procedures often require holding prophylaxis. Think lumbar puncture, epidural catheter placement, liver biopsy, kidney biopsy, or major non-vascular surgery, especially neurosurgery or spine surgery. There's usually a specific time window, often 12-24 hours post-procedure, where anticoagulation is held to allow hemostasis.
What about trauma?
Severe trauma, particularly to the head, spinal cord, or major extremity trauma within the preceding 24 hours, is also a strong relative or absolute contraindication, even if there isn't obvious active bleeding, due to the risk of delayed hemorrhage or hematoma expansion.
Okay, those cover the more clear-cut contraindications. But assessing bleeding risk is often more nuanced, isn't it? There's a whole list of other factors that increase risk, even if they aren't absolute stops.
That's right. This is where clinical judgment really comes in, weighing the VTE risk score against these bleeding risk factors. It's often a constellation of things.
Like what?
Well, advanced age itself, usually considered over 75 or 80, increases baseline bleeding risk. Female sex is also consistently shown to be an independent risk factor for bleeding complications with anticoagulation.
And comorbidities play a huge role. You mentioned liver disease already. What about kidney disease?
Severe chronic kidney disease is a major one. Impaired renal clearance, especially with a creatinine clearance below 30 milliliters per minute, causes LMWH to accumulate, significantly increasing bleeding risk. Uremia itself can also impair platelet function.
Diabetes, hypertension.
Yes, diabetes and uncontrolled hypertension can contribute, likely through effects on vascular integrity. Active cancer, while increasing VTE risk, can also increase bleeding risk, depending on the type, location, and treatments like chemotherapy causing thrombocytopenia.
What about lifestyle factors or history?
History of peptic ulcer disease, especially recent, is a concern for GI bleeding. Chronic alcoholism often links with liver disease and coagulopathy. Prior stroke increases the risk of hemorrhagic transformation if anticoagulated. Even anemia at baseline could be a marker of higher bleeding risk or lower tolerance for blood loss.
And then there's the issue of polypharmacy, other drugs the patient is taking.
Absolutely critical to review the medication list. Concomitant use of antiplatelet agents aspirin, clopidogrel, significantly increases bleeding risk when combined with anticoagulants. NSAIDs are notorious for increasing GI bleeding risk.
What else?
Even some antibiotics, certain statins, fibrates, or systemic steroids, can potentially interact or increase bleeding risk in susceptible individuals. It's the cumulative effect. A patient with moderate VTE risk but multiple bleeding risk factors, say elderly, CKD, on aspirin, might have their overall risk-benefit calculation shift away from pharmacologic prophylaxis.
So if that calculation does shift, if pharmacologic prophylaxis is deemed too risky due to these absolute or relative contraindications, what's the alternative?
Then we pivot immediately to mechanical prophylaxis. This is the mainstay for patients with a high bleeding risk.
And the main options here are intermittent pneumatic compression devices, IPCs, and graduated compression stockings, GCS, often called TED hose.
Correct. Those are the two primary methods.
Is one preferred over the other?
Yes. Generally, intermittent pneumatic compression, IPC, is the preferred modality when mechanical prophylaxis is indicated.
Why IPCs over stockings?
IPCs are an active system. The inflatable sleeves rhythmically compress the calf and/or thigh, actively squeezing the veins, increasing blood flow velocity, and reducing stasis. This mechanism has been shown in studies to be more effective at preventing DVT compared to no prophylaxis, and generally more effective than stockings alone.
So GCS or stockings are less favored now.
They are less favored, particularly in acutely or critically ill patients. The evidence for their efficacy is much weaker and more mixed compared to IPCs.
Are there downsides to stockings?
Yes. Besides inconsistent efficacy, especially if not fitted perfectly, or if a patient has significant leg edema, GCS have been associated with higher rates of device-related skin injury. Pressure sores, blisters, even skin necrosis can occur, especially over bony areas or if left on improperly for long periods. Given IPCs have better efficacy data and potentially a better safety profile when monitored, they've become the standard mechanical approach.
But even IPCs aren't a perfect substitute for drugs, right? What are the limitations or caveats we need to remember with mechanical methods?
Absolutely not a perfect substitute. The first major caveat is efficacy. Mechanical methods, even IPCs, are generally considered less effective at preventing VTE than correctly dosed pharmacologic prophylaxis in high-risk patients. They reduce risk, but not as much as anticoagulants do.
Okay, less effective. What else?
The second point is the question of adjunctive use. Should we use IPCs in addition to pharmacologic prophylaxis in high-risk patients?
That's a common practice in some places.
It is, but the evidence supporting a significant added benefit from combining mechanical and pharmacologic prophylaxis is actually quite limited and inconsistent across guidelines. Some studies suggest a small potential benefit in the highest risk groups, like major orthopedic or trauma patients. But for general medical or surgical patients already on adequate anticoagulation, adding IPCs may just increase cost and potential for skin issues without clear additional VTE reduction. It shouldn't be a reflexive order.
Good point. Are there contraindications to using mechanical devices themselves?
Yes, definitely. You wouldn't want to place IPCs or stockings on a leg with significant trauma, open wounds, severe skin conditions like cellulitis, or known acute DVT. Though the risk of embolization from compression is debated, it's generally avoided. A critical contraindication is severe peripheral arterial disease, PAD. Compressing an already ischemic limb could worsen perfusion and lead to tissue damage.
Improper use and monitoring are key.
Non-negotiable. Devices need to be properly sized for the patient. Nursing staff need to regularly check skin integrity, especially over pressure points like the heel or fibular head. Ensure the device is functioning correctly and worn consistently when the patient is in bed or chair. And we need to educate patients and staff that while ambulation is encouraged, simply walking a few steps now and then isn't considered adequate VTE prophylaxis on its own for a truly high-risk hospitalized patient.
Okay, that covers the main modalities and their limitations. Let's move into some specific, often challenging patient populations where the standard approach needs tailoring. First up, the critically ill ICU patient.
Right. The ICU population is at markedly elevated VTE risk. They often have profound immobility, systemic inflammation from sepsis or shock, multiple lines, sometimes vasopressors, a perfect storm.
What's the preferred pharmacologic agent in the ICU?
Generally, low molecular weight heparin, LMWH, is preferred over UFH for VTE prophylaxis in critically ill patients.
Why is that?
Some evidence, including meta-analyses, suggests LMWH may be more effective than UFH in reducing DVT incidence specifically in the ICU setting. The reasons aren't perfectly clear. Could be better bioavailability in patients with peripheral edema or altered perfusion, or perhaps less interaction with acute phase reactants compared to UFH.
And if the ICU patient has a high bleeding risk, which is common.
Very common. Given frequent procedures, coagulopathies, fluctuating platelets, if pharmacologic prophylaxis is contraindicated due to high bleeding risk, then mechanical prophylaxis with IPCs is mandatory. It should be initiated promptly and continued until the bleeding risk decreases enough to allow safe initiation of anticoagulation.
Makes sense. Next special population. Patients with severe renal failure, say a creatinine clearance less than 30 LE-min. We touched on this with bleeding risk.
Yes, this is a critical safety modification.
Yeah.
LMWH relies heavily on renal clearance. In severe renal impairment, LMWH and its active metabolites accumulate, the half-life extends, and the bleeding risk skyrockets.
So LMWH is generally contraindicated.
Contraindicated, or requires significant dose reduction and anti-HESA level monitoring, which can be cumbersome. Therefore, the preferred agent for VTE prophylaxis in patients with CRCL 30 ml-min is unfractionated heparin, UFH.
What dose of UFH?
Typically, UFH 5,000 units subcutaneously every 8 to 12 hours. The every 12 hours regimen might be chosen if bleeding risk is also a concern, while every 8 hours might be used if VTE risk is felt to be very high. UFH clearance is less dependent on the kidneys, making it a safer choice, although careful clinical monitoring for bleeding is still essential.
Okay, clear shift to UFH in severe CKD. Now, the other end of the spectrum, patients with severe obesity, usually defined as a BMI over 40.
Another significant challenge. Obesity alters drug pharmacokinetics, volume of distribution changes. Subcutaneous absorption can be less predictable.
Meaning the standard LMWH dose might not be enough.
Exactly. Studies using anti-factor Zage level monitoring have shown that standard doses, like enoxaparin 40 mg daily, often result in subtherapeutic drug levels in patients with BMI 40. This correlates with higher rates of breakthrough VTE.
So what's the approach?
We need to consider dose adjustment. A common strategy is to increase the LMWH dose, for example, using enoxaparin 40 mg twice daily, BID, instead of once daily. Some protocols might use weight-based adjustments or even higher fixed doses like 60 mg daily or BID in very large patients.
Does this require monitoring?
This is one of the few situations where monitoring prophylactic LMWH with anti-factor Za levels is often recommended. The goal is to titrate the dose to achieve a target trough or peak level that's known to be protective, ensuring efficacy without causing excessive anticoagulation. It's individualized dose optimization.
Got it. Next group, hospitalized patients with active cancer.
Cancer patients are inherently high risk due to the hypercoagulable state associated with malignancy itself, often compounded by chemotherapy, immobility, or surgery.
Preferred agent.
Again, LMWH is generally preferred over UFH for VTE prophylaxis in hospitalized cancer patients based on studies showing potential superior efficacy, particularly in preventing VTE long-term.
Is risk stratification needed within cancer patients, or are they all considered high risk for inpatient prophylaxis?
While all hospitalized patients with active cancer are generally considered high risk and warrant prophylaxis, tools like the Corona score exist. However, the Corona score is primarily validated and used for predicting VTE risk in the outpatient setting, specifically for patients starting chemotherapy to guide decisions about outpatient prophylaxis. In the inpatient setting, active cancer itself usually pushes the patient into a high-risk category requiring prophylaxis, typically with LMWH, throughout their hospital stay.
Okay, two more specific scenarios. Major orthopedic surgery.
This is a distinct category because the VTE risk associated with major orthopedic procedures like total hip or knee replacement or hip fracture surgery is very high and extends well beyond the hospital stay.
So standard inpatient prophylaxis isn't enough.
Correct. These patients require mandated extended duration prophylaxis, typically lasting anywhere from 10 days up to 35 days. There's more flexibility here. Options include LMWH, fondaparinux, DOACs like rivaroxaban, apixaban, dabigatran, or warfarin. The choice often depends on surgeon preference, patient factors like renal function, bleeding risk, cost, and ease of use. The critical point is the duration. It must extend significantly beyond discharge.
And finally, patients admitted with acute stroke.
The key here is the initial assessment. Stroke can be ischemic or hemorrhagic, and giving anticoagulants in hemorrhagic stroke is disastrous.
So imaging first is crucial.
Absolutely paramount. Pharmacologic prophylaxis, typically with LMWH or UFH, should only be initiated after brain imaging has definitively ruled out hemorrhage.
What if imaging is delayed or if the patient has other high bleeding risks?
If there's any suspicion of hemorrhage, or if the patient is otherwise at high risk for bleeding, NGD, uncontrolled hypertension, large infarct size with hemorrhagic conversion risk, then you must rely solely on mechanical prophylaxis, usually with IPCs, until the situation is clarified and pharmacologic agents are deemed safe. Early mobility is also encouraged once stable.
That careful balancing act really brings us to the discussion about the duration of prophylaxis, especially for the general medical patient. Standard versus extended duration.
Right. For the typical acutely ill medical inpatient identified as high risk, Padua 4, standard practice is to provide prophylaxis for the duration of their acute illness or significant immobility, essentially while they are in the hospital.
How long is that usually?
It generally ranges from about 6 to 14 days, correlating with the typical length of stay for many acute medical conditions. Guidelines are quite clear that for most of these patients, prophylaxis should be stopped at hospital discharge.
But we know the VTE risk doesn't just vanish the moment they walk out the door, right? It often peaks in the weeks following discharge.
That's the conundrum. The risk certainly persists, often highest in the first 30 to 45 days post-discharge. This led to the studies on extended duration prophylaxis we discussed earlier, using agents like petrixaban or rivaroxaban for up to 35 or 45 days.
But as you said, routine extended duration isn't recommended for most medical patients. Why reiterate that?
Because the risk-benefit trade-off is so marginal for the average patient. Those meta-analyses consistently showed that while extended duration does reduce VTE events compared to stopping at discharge,
It comes at a cost.
it comes at the cost of a definite, statistically significant increase in major bleeding. When you calculate the numbers needed to treat NNT to prevent one VTE event with extended prophylaxis, it's often quite high, maybe in the hundreds.
And the number needed to harm.
The number needed to harm NNH for causing a major bleed was often uncomfortably close to the NNT, sometimes even lower in certain analyses or subgroups. That implies you might be causing as much or more serious harm from bleeding as you are preventing benefit from VTE reduction in an unselected population.
That's a stark finding. It really argues against routine extension.
It does. It means we would likely be harming a significant number of lower-risk patients to benefit a smaller number of truly high-risk ones.
So who does qualify for extended duration prophylaxis after a medical admission? It must be a very select group.
Extremely select. It should only be considered for patients who have both exceptionally high ongoing VTE risk factors persisting after discharge. Think persistent severe immobility, like someone bedbound from stroke, certain high-risk active cancers, maybe a history of multiple prior VTEs, and concurrently have a clearly documented low risk of bleeding.
So it requires a very deliberate, documented decision that the expected VTE benefit strongly outweighs the bleeding risk for that specific individual.
Exactly. It's a case-by-case decision, not a routine pathway. And it often involves shared decision-making with the patient about the risks and benefits.
Managing this complex balance requires ongoing vigilance. We need robust monitoring strategies looking at both safety and efficacy. Let's talk about pharmacologic safety monitoring first.
Safety monitoring is continuous. Clinically, we need constant awareness for signs of bleeding, looking for bruising, petechia, checking stool and urine for blood, monitoring surgical sites or line sites. Any unexplained drop in hemoglobin should trigger concern for occult bleeding.
What about lab monitoring? Platelets.
Yes. Routine monitoring of platelet counts is standard, especially when using unfractionated heparin to screen for heparin-induced thrombocytopenia, HIT. The frequency depends on the setting, but typically every few days initially. A significant drop in platelets, for example, 50% from baseline, requires stopping heparin immediately and investigating for HIT. Even with LMWH, while the risk is lower, platelet monitoring is still generally recommended, particularly with prolonged use.
Okay, that's safety. What about monitoring for efficacy? We mentioned anti-factor XA levels earlier. When are those necessary?
Right, anti-XA levels measure the activity of LMWH or fondaparinux. Routine monitoring isn't needed for most patients getting standard prophylactic doses because the response is predictable. However, it becomes crucial in specific situations where pharmacokinetics might be altered.
Like the ones we discussed.
Exactly. The main indications for checking anti-XA levels to ensure therapeutic prophylaxis are severe obesity, BMI 40, especially if using adjusted doses like enoxaparin 40 mg BID and severe renal impairment, CRCL30, even if using UFH, particularly if dose-adjusted LMWH is attempted, though UFH is preferred. It's also sometimes considered in pregnancy.
What's the goal of checking the level?
The goal is to confirm that the chosen dose is achieving adequate factors A inhibition to be protective. We know that subtherapeutic anti-A levels in these high-risk populations correlate strongly with prophylaxis failure and breakthrough VTE. Conversely, excessively high levels would increase bleeding risk. So it's about ensuring the dose is right for that individual.
Titrating to a target range?
Essentially, yes.
Yeah.
Targeting a specific peak or trough anti-A level known to be associated with effective prophylaxis.
And we also need to monitor the mechanical devices, right? They aren't risk-free.
Definitely not. Mechanical device monitoring falls heavily on nursing staff, but requires physician awareness too. Key is regular skin inspection. Checking under the sleeves or stockings for redness, pressure areas, blistering, or breakdown, especially over bony prominences like heels, ankles, and the fibular head.
How often?
At least once per shift, or more frequently in very high-risk patients, for example, those with peripheral edema, poor sensation PAD. We also need to ensure the device is applied correctly, sized properly, and functioning as intended. VAG IPCs are inflating and deflating. A poorly fitted or malfunctioning device is useless and potentially harmful.
Despite having these tools and guidelines, we know that appropriate VTE prophylaxis isn't always implemented correctly. There are systemic failures. What are the common gaps we see?
It's unfortunately true. Implementation remains a challenge. The failures tend to fall into two main buckets. Underuse in patients who clearly meet high-risk criteria and absolutely should be receiving prophylaxis. And conversely, overuse in patients who are low risk, for example, fully mobile, low Padua Caprini scores, and are being exposed to bleeding risk without significant benefit.
Both are quality and safety issues.
Major issues. Underuse leads to preventable VTEs, PEs, and death. Overuse leads to preventable bleeding complications, increased costs, and potential patient harm. Achieving consistency is key.
So how do we bridge these gaps? What system-level interventions actually work?
It requires a multifaceted approach. Simple education or passive guideline dissemination often isn't enough.
Needs to be more active.
Yes. Standardized processes help things like mandated VTE risk assessment for all admitted patients using the validated scores, Padua Caprini. Incorporating this into admission order sets or nursing workflows. Using pre-printed orders or electronic order sets that guide appropriate prophylaxis selection based on the risk score and contraindications.
What about technology? Alerts?
That seems to be where the biggest impact comes from. Numerous studies have shown that implementing computerized clinical decision support CDS systems yields the largest and most sustainable improvements in appropriate VTE prophylaxis rates.
How do those work?
These systems can automatically calculate the Padua or Caprini score based on data already in the electronic health record, age, diagnoses, mobility status. They can then alert the ordering physician at the point of care if prophylaxis seems indicated but hasn't been ordered, or if potentially inappropriate prophylaxis, e.g. LMWH in severe CKD, is ordered. They can also flag contraindications.
Basically making it harder to miss or make a mistake.
Exactly. They embed the evidence-based logic into the workflow, acting as a forcing function to ensure risk assessment happens and appropriate choices are prompted. It moves beyond individual reliance towards a safer system.
Okay, so pulling this all together after this deep dive, the core message seems to be that effective, safe VTE prophylaxis isn't about just picking a drug. It's a systematic process.
It absolutely is. It starts with consistent, mandatory, individualized risk assessment, using the right tool, Padua for medical, Caprini for surgical. Then it's about critically evaluating the patient's bleeding risk profile simultaneously.
And then choosing the right intervention based on that balance.
Right. Pharmacologic prophylaxis, usually LMWH or UFH, for those deemed high VTE risk with acceptable bleeding risk. Mechanical prophylaxis, preferably IPCs, reserved only for those where pharmacologic agents are contraindicated due to high bleeding risk. And then tailoring the agent and dose for special populations like renal failure or obesity, often requiring monitoring. And finally, getting the duration right, typically stopping at discharge for most medical patients.
It's a continuous cycle of assessment, intervention, and monitoring.
Precisely. Vigilance is key throughout the hospital stay.
So thinking ahead, We've talked about the challenge of post-discharge risk and the tricky balance of extended prophylaxis, where the NNT and NNH are often too close for comfort in unselected medical patients. This leaves us with a really important clinical question to ponder. How can we get better at identifying which specific patients, after hospital discharge, truly stand to gain a net benefit from that longer, say 35-day course of anticoagulation? We need tools that go beyond our current static inpatient risk scores. What might those look like? Could we use biomarkers, maybe integrate functional status post-discharge, develop dynamic scores?
That's the million-dollar question, isn't it?
Yeah.
Finding a reliable way to pinpoint that narrow subset of post-discharge patients where the VTE risk remains sufficiently high and the bleeding risk remains sufficiently low to justify extended prophylaxis. It likely involves integrating clinical factors, maybe inflammatory markers that persist, D-dimer levels, functional assessments, perhaps even genetic markers someday.
Developing and validating those more refined, maybe even real-time post-discharge risk stratification tools seems like the next major frontier. Getting that balance right has huge implications for patient safety and healthcare resources.
It really does.
Yeah.
Because right now, we're likely undertreating some who would benefit from extended prophylaxis and potentially overtreating others if we apply it too broadly, based on inpatient risk alone. Solving that puzzle would be a major advance.
A critical challenge for hospital medicine, indeed. Well, this has been an incredibly thorough exploration. Thank you for joining this deep dive into evidence-based VTE management.
My pleasure. It's a vital topic to get right.